Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session on GDM in 2025. From diagnosis to nutrition, treatment, and stillbirth prevention, what every gynecologist must master. With much pleasure and honor, let me welcome today's host with us, Dr. Sharda Jain ma'am. Ma'am is a senior consultant of Ops and Gynecology Department, Director of Life Care Center and Life Care IVF, Expert Ethical Committee in NMC, Secretary General of DGF, Founder and Chairman of North Indian Gynecologist Forum. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am. Welcome, ma'am.
Thank you, Shion, and thank you for giving us this platform. My good afternoon to everybody. Today we are going to discuss on this national platform gestational diabetes. Gestational diabetes is needed for all gynecologists, for all medical officers, nurses. They must have a great knowledge about gestational diabetes. As you all know, that it can cause glucose intolerance, which can harm both mother and the baby, and if not managed properly. India has an incidence of gestational diabetes. 15 to 20% pregnant patients have gestational diabetes as compared to only 5% in the Western world, less than that. And if it remains untreated, undiagnosed, then it can lead to, as far as the baby is concerned, it can create a havoc in the terms of macrosomia, stillbirth, and because of the big size, there can be birth trauma, and in neonatal period, neonatal hypoglycemia. As for the mother is concerned, she has additional problems of preeclamptic toxemia, and later on, both the mother and the baby stand to have this type 2 diabetes in future, and whole Pandora box of non-communicable diseases. So I think, we have got a team of 5 stalwarts which are going to speak and dwell on it. It is going to be a 10 minutes presentation by each. We have a team. Dr. Seema is going to start. She's the secretary of Delhi Gynecologist Forum East. Followed by, we have Renu Chawla. She will be speaking on the medical nutritional therapy as far as gestational diabetes is concerned. Then we will have Dr. Deepthi Nab. She is the president of Delhi Gynecologist Forum East. She's going to talk about the medical treatment, both metformin and insulin. And finally, we are going to have talk on the perinatal aspect. Dr. Meenakshi is going to speak stillbirth and beyond. She's going to speak. She's again the senior vice president as for the Delhi Gynecologist Forum East is concerned. And finally, we have another expert, very decorated, Dr. Archana Verma. She had been a past president of Foxy. She will be making expert comment. So without waste of time, I will ask our opening batsman, Seema, to start her presentation. I'll make a presentation in just 1 minute for her.
Thank you so much, ma'am, for inviting us the opportunity. And thank you, IJCP, for discussing such an important topic.
Just 1 minute, Seema.
Okay.
Go ahead.
Thank you, ma'am. Today we are going to discuss the overall view of GDM. We all know gestational diabetes mellitus is one of the most common medical conditions in pregnancy, and its prevalence is growing with increasing rates of women of advanced age becoming pregnant. So the increasing incidence is because of the maternal obesity and also inactivity. And we Asians, and especially we Indians, are at a greater risk of diabetes mellitus, and hence pregnant women are at greater risk of gestational diabetes. Let's understand the physiology. Why do we have GDM? The normal pregnancy is associated with insulin resistance, similar to that which we see in type 2 diabetes. This physiological resistance to insulin during pregnancy is important and is more apparent in the second trimester, and insulin resistance increases progressively to term. Changes in insulin resistance occur to facilitate transport of glucose across the placenta to ensure normal fetal growth and development. And transfer of glucose across the placenta stimulates fetal pancreatic insulin secretion, and insulin acts as essential growth hormone, so it is important for the growth of the fetus. What is GDM? GDM is defined as carbohydrate intolerance resulting in hyperglycemia of variable severity. It can be with onset or first recognition during pregnancy. GDM defined in this way includes women with undiagnosed pre-existing diabetes as well as women with first onset hyperglycemia during pregnancy. So it includes both. Now, FIGO recommends using the term hyperglycemia in pregnancy, whether it is diabetes before pregnancy, during pregnancy, or because of pregnancy. So it's a common term for all the types of hyperglycemia that we see. Now, coming to some facts about GDM. GDM, we say, is when it's diagnosed during pregnancy. And in India, according to the Government of India data, the prevalence of GDM is around 18% in urban population, around 14% in semi-urban, and around 10% in rural area. And in most of the cases, almost 90%, it disappears after delivery. But 50% of women may develop diabetes in 5 to 10 years. This is very important. And of these GDM cases, 70% patients don't need medication and they are controlled on diet and exercise only. So screening during pregnancy can save both the mother and the child from the ill effects of GDM. In India, we have one very simple and important test that we do to screen all the women. The screening in India is universal, unlike other countries. We use GDM is important to screen women because we have many maternal and fetal complications. Maternal complications include polyhydramnios, preeclampsia, we may have prolonged labor, it may lead to obstructed labor, higher incidence of cesarean sections, and because of the macrosomic babies, we may have uterine atony, which may lead to postpartum hemorrhage, increasing incidence of infection and retinopathy. These are the leading global causes of maternal morbidity and mortality. Coming to the fetal complications, fetal risks include spontaneous abortion, intrauterine death, which is very harmful, stillbirth, congenital malformation, shoulder dystocia, birth injuries. There may be neonatal hypoglycemia and may even have infant respiratory distress syndrome. And we also have long-term clinical implications of GDM, which are the important contributors to the burden of non-communicable diseases in our country. Now, how do we identify GDM? This is a screening test which is done universally for all the pregnant women. This universal screening of GDM, pregnant women are given by a GIPSy test, which is a 2-hour glucose tolerance test. And if the value is less than 140 after 2 hours, it is taken as non-GDM and the patient is managed. And we repeat the test again at 24 to 28 weeks and see for the level. If it is less than 140, the patient is continued and monitored as normal ANC patient. However, if it is more than 140, then we need to manage the patient as GDM patient. Now, how do we do this test? This is a GIPSy method test, single-step test. We give 75 gram oral glucose to the mother, and this glucose is dissolved in 300 ml of water, and the woman is allowed to take this in around 5 to 10 minutes, whether she comes fasting or non-fasting. This is very important so that we do not miss any patient because of the fasting state. The intake of the solution has to be completed in 5 to 10 minutes, and after 2 hours, a plasma standardized glucometer is used to see the blood sugar level. However, if vomiting occurs within 30 minutes, the test has to be repeated the next day. And if the vomiting occurs after 30 minutes, we continue the test as such. The threshold blood sugar level of more than or equal to 140 is taken as a cutoff for diagnosis of GDM. Now, testing for GDM is done twice during ANC. The first testing is done during the first antenatal contact as early as possible in pregnancy. The second test should be done during 24 to 28 weeks if the first test is negative. It is important to ensure second test as many pregnant women develop blood sugar intolerance during this period after the second trimester or in the second trimester because of the increased intolerance. And also only 1/3 of GDM positive women are detected in the first trimester. So we should always test the women again in the second trimester to see for any GDM present. And the gap between two tests should be at least 4 weeks. All pregnant women who test positive for GDM for the first time are started on medical nutrition therapy and physical exercise, which is given for 2 weeks. The woman should walk or exercise for 30 minutes every day, and a diet appropriate to the GDM is asked to be followed. And after 2 weeks, we see again the 2-hour postprandial blood sugar. And if it is more than 120, we take the patient as GDM and manage accordingly. So if 2-hour postprandial blood sugar is less than 120, we repeat the test every month during the second and third trimester, and more follow-up tests can be done if required. And if it is the postprandial blood sugar is more than 120, a medical management has to be started as per the guidelines. The management we can all see, if it is more than 120, we manage the patient as GDM, and accordingly we can give either the medical nutrition therapy, we already started that, and we have to give the pharmacotherapy to control her blood sugar and manage the problems associated with the mother and the baby. These all are special obstetric care for all women with GDM is very important. All cases diagnosed before 20 weeks. A fetal anatomical survey morphology scan is to be done at 18 to 20 weeks because these fetuses are at more risk of anomalies. And a fetal growth scan should be performed at 28 to 30 weeks and again repeat at 34 to 36 weeks. There should always be a gap of at least 3 weeks between the two ultrasounds. And all the ultrasounds should include a fetal biometry and the amniotic fluid estimation. How do we monitor these patients? We have to set some glycemic targets. A fasting and postprandial self-monitoring of blood glucose is recommended. And fasting plasma glucose should be maintained less than 95 mg%, and a postprandial less than 140, which is 1 hour, and 2-hour postprandial less than 120. So all patients should be monitored on self-monitoring of blood glucose. And for the fetal surveillance, a vigilant fetal surveillance is required. Fetal heart rate should be monitored by auscultation on each antenatal visit. The pregnant woman should be explained about the daily fetal activity, which is very important. And she is asked to lie down on her side after a meal and note the number of kicks. If it is 10, it is okay. If the fetus does not kick 3 times within 1 hour or minimum of 1 time in 1 hour, she should consult her doctor. Next one. Now, during the labor and delivery, all these pregnant women with GDM with good control of blood sugar can be delivered at their respective health facility. Ideally, they should all have institutional delivery. Pregnant women with GDM on insulin therapy or with uncontrolled sugar levels on MLT and physical exercise and who require insulin or metformin should always deliver at higher center, which is very important. Timing of delivery. GDM pregnancies are associated with rare lung majority, so routine delivery prior to 39 weeks is not recommended. Vaginal delivery is preferred. LSCS should be done only for obstetric indications. And in case of fetal macrosomia, estimated fetal weight more than 4 kg, we should opt for elective cesarean section at 39 weeks to avoid shoulder dystocia. Now coming to the postpartum issues with GDM, postpartum aim should be early detection of infection, support of breastfeeding. The advice on pregnancy spacing, contraception is very important, and we should retest all women with GDM at 6 to 12 weeks postpartum, and Future blood glucose test should always be followed up 3 monthly, 6 monthly, and yearly to see for any development of diabetes mellitus in the later life. Post-delivery follow-up of pregnant women with GDM. Immediate postpartum care of GDM is not different from women without GDM, but since these women are at high risk of developing diabetes mellitus, maternal glucose levels usually return to normal after delivery. Subsequently, 75 gram OGDT, as we were already doing, is done at 6 weeks postpartum to evaluate the glycemic status. Pregnant women with GDM and their offspring are at increased risk of developing type 2 diabetes. They should be counseled for healthy lifestyle behavior, particularly role of diet and exercise, which is very important for the future life. GDM is a window of opportunity. FIGO supports the concept that postpartum period in women with GDM provides an important platform to initiate early preventive health for both the mother and the child, because there are both increased risk of obesity, diabetes, and hypertension. So to conclude, GDM can be easily controlled by diet, exercise. Only a few women in whom blood sugar is not controlled by diet require oral diabetic agents or insulin therapy. GDM can be treated with oral metformin tablets as they do not harm the fetus. Insulin injections are required only during pregnancy, and in most cases, insulin is stopped after delivery. Injecting insulin over the abdomen is 100% safe. Modification of diet is very easy. Ideally, sweets should not be avoided. Refined carbohydrates should be avoided. If the blood sugar is controlled, patient and the baby are safe. So we should always screen all the patients to decrease the incidence of GDM and prevent the future morbidity and mortality in both the mother and the baby. Thank you.
Thank you very much, Dr. Seema, to give an overview of things. Now we will have a second presentation by Dr. Renu Chawla. Dr. Renu Chawla is a Senior Vice President of Delhi Gynaecologist Forum East and interested in this particular field of GDM treatment. Dr. Renu Chawla, over to you.
Thank you, ma'am, for giving me this opportunity.
Shion, you have to help with the screen. रेनू शेयर करो अपना.
मैम मैंने शेयर उनको दिया हुआ है. She said she'll share the slides.
Yes.
Good afternoon, everyone. So the topic for today is medical nutrition therapy in gestational diabetes mellitus. You'll be shifting the slides, or I have to shift? Sion? Next slide.
Ma'am, you can change the slides from your end.
You have change the slide.
No, it is not getting changed. That is why I'm asking.
Ma'am, there's the arrows in your keyboard.
Yeah.
Yeah. Click on the right arrow, ma'am.
Yeah.
Yes.
Okay.
It will get changed like that.
Okay.
Yes.
So the importance
of stick to your time.
Yes, ma'am. The nutritional, I think we need to little enlarge the slides. The font is very small then. Can it be enlarged a little bit?
No, ma'am. You can enlarge the screen, but the slides can't be enlarged more than that.
Okay. So nutritional assessment in GDM should be individualized. This includes defining her body mass index or percentage of desirable pre-pregnancy body weight and optimal pattern of weight gain during pregnancy. Calories and GDM individualization is important when determining energy requirements, and adjustment should be made based on the weight changes which occur in pregnancy. Energy requirements during pregnancy include the normal requirement of adult and an additional requirement for the fetal growth, plus the increase in the body weight or of the pregnant woman. Energy requirements does not increase in the first trimester unless a woman is underweight. Energy requirements increase during second and third trimester. Energy intake should be adequate enough to provide appropriate weight gain during pregnancy. The importance of individualized nutrition assessment in GDM is, as per Indian ICMR guidelines for an average weight gain of 10 to 12 kgs, an additional of 350 kilocalories per day above the adult requirement is recommended during second and third trimester. Severe caloric restriction is not recommended as it may result in ketonemia and ketonuria and impair physical and mental development in the offspring. So the level, depending on the level of activity, if she is a sedentary worker, her energy requirements as such are 1900 kilocalories. So during pregnancy, we add 350 kilocalories. That makes it 2250. Similarly, for the moderate worker, it will be 2580. And for someone who's doing a heavy work job, the calorie intake should be 3200 calories. So, diagnosis and management of gestational diabetes mellitus, technical and operational guidelines, Maternal Health Division, Ministry of Health and Family Welfare of India. They say that addition or deduction of 500 calories per day is recommended as per following table. If the woman is underweight, that is her BMI is less than 18.5, then the energy requirement as per level of activity should be provided to her in addition with an addition of 500 kilocalories per day. So if she is a normal weight with a BMI of 18.5 to 22.9, then the energy requirement as per level of activity. If she is obese, overweight, then her energy requirement as per the level of activity. But in obese patients whose BMI is more than 25, energy requirement as per level of activity minus 500 kilocalories per day. This is a very important point, and it should be noted that if she is obese and with a BMI of more than 25, then she should have minus 500 kilocalories for her requirement. So caloric requirement should be 35 kilocalories per kg for low BMI and 30 kilocalories per kg for normal BMI and 25 kilocalories per kg for high BMI. So hypocaloric, but we should take care that hypocaloric diets in obese women with GDM can adversely impair fetal growth and they may result in ketonemia and ketonuria. So diet restriction has to be decided judiciously. However, moderate caloric restriction, that is reduction by 30% of estimated energy needs in obese women with GDM, may improve glycemic control without ketonemia and reduce maternal weight gain. So diet should be balanced as follows. It should include carbohydrates, almost 50 to 60%, proteins 20 to 25%, and fats 25%. So diet chart meal plan for women with GDM, it should be ideally prescribed by the dietitian as per because it has to be tailor made according to each and every individual. So if some expert dietitian is giving the diet plan, it is better. But we can also, gynecologists can also guide the patients on their diet plan. Meal plan should be divided into 3 major meals: breakfast, lunch, and dinner, and 2 to 3 snacks in between them. Women should eat food which is easily available at her home with little modifications in the diet. Like she should reduce the number of chapatis. If she has, like, the number of chapatis in one meal should not be more than one or two. At one time, she should eat either rice or chapati. If she mixes both, then she should take care of the quantity. The woman should follow discipline regarding meal timings, eat food at the same time if possible, avoid fried foods, sweets, juices, and organ meats. Meal should meal thali should be divided into two halves. Fill one half with vegetables, salads, and fruits. Divide other half into two equal halves. One for proteins like dal, meat, curd, and other half for roti or rice. She should include all food groups in her daily diet, that is cereal, whole grains, pulses, milk and milk products, fruits, vegetables, and little amount of fat. The woman must drink water, buttermilk, soups, soya milk, and other unsweetened healthy beverages instead of soda or fruit juices. So this is the normal 1800 calories sample meal plan for a patient with GDM. So with this, we know that she should have three major meals like breakfast, lunch, and dinner, and three snacks. But care should be taken that they should not be nutrient rich and rich in sugar and high glycemic index foods. So these charts are available on Government of India site, and one can always download and read them in detail. This is a 2000 calorie sample meal plan for GDM, and there are nobody can eat the same foods as they are listed in these charts, but food exchange list is already given by them, so that if you do not want to eat one food, then exchange it with the same calorie pattern of the other food. One should not exchange it with the more calorie food, so it will imbalance her diet and will not be able to control her GDM. Physical activity and exercise. Physical activity for women with GDM. Exercise can provide maternal benefits. It will help in minimizing the weight gain, and it will improve glycemic control and prepare her for physical rigor of labor. Fetal benefits include potential reduction in the fetal adiposity. Schedule of exercise. Patient should have at least 20 to 30 minutes of physical activity daily, and that should be 5 times a week. Moderate exercise if she does with low, she can do that also if her body allows, but she should take care that there should not be any increased risk of fall. So she should follow an exercise schedule under supervision so that there is minimum risk of fall. Most days of a week she can do exercise, and she should take care that she should not miss exercise for more than 2 days in consecution. So physical activity exercises, these are the exercises she can undertake, but as said, the exercises should be supervised, and she should not do exercises which have increased risk of fall. So
When you
target
wind up.
glucose, Ji ma'am. As recommended by ADA and ACGA, the target glucose levels are: fasting should be less than 95, preprandial less than 100, and 1 hour postprandial less than 140, 2 hour postprandial less than 120. Midnight should be more than 60 milligrams per deciliter. These are the upper limits of desirable glucose levels. So medical nutrition therapy, its principles of MNT are healthy eating during pregnancy. All pregnant women with GDM should get medical nutrition therapy as soon as the diagnosis is made. MNT for GDM primarily involves a carbohydrate controlled balanced meal plan which promotes optimal nutrition for maternal and fetal health, adequate energy for appropriate gestational weight gain, and achievement and maintenance of normoglycemia. So this is the composition of thali, which I had specified, and management of pregnant women with GDM. This is in summary that once the patient has been diagnosed with GDM, she should be put on MNT and exercise for at least 2 weeks. And after 2 weeks, when you repeat the 2 hours PP levels, if they are less than 120, then continue with exercise and MNT. If the levels are more than 120, then she should be put on metformin or insulin as required. Thank you.
Wonderful, Dr. Renu, for telling that your diet should not be less than 18 and your control of blood sugar should be less than 120 at 2 hours. Because in case if the blood sugar is not controlled, the fetal growth is going to be more and whole lot of fetal complications are going to be as a result of the same. So now once you know that blood sugars and your blood sugars are not maintained and they are always more than 120 at 2 hours, you start a medical treatment. So to address that, we have Dr. Deepthi Nab. Dr. Deepthi Nab is the president of Delhi Gynaecologist Forum East, and she's going to do justice by making her presentation in 8 to 9 minutes. Over to you.
Thank you so much, ma'am. Good afternoon, everyone. Can we have the slides, please?
Shriyan, please let's have the slides.
Yes, yes. Ma'am, you have logged into the full screen mode. Just log out from that full screen mode, ma'am.
Okay, done.
Who, me?
Yes, yes, Dipti ma'am.
Yeah, done.
Yeah. Yeah. Now minimize the Chrome and open your PPT, ma'am.
Okay.
It will work. Yes.
Okay. So,
Your slides.
good afternoon, everyone. My slides are visible?
Yes, ma'am. It is.
Make it full screen.
Ji, ma'am. Okay. So, I
Wonderful.
start. Ji, thank you, ma'am. I start with my topic, that is medical treatment of GDM. So, Dr. Renu has already told us that the initial management is with MNT and physical exercise. But if after 2 weeks of this mode of treatment, the postprandial 2-hour blood sugar is more than 120 milligrams, then medical management is to be started as per the guidelines. Insulin and metformin are the drugs for medical management. We start generally with, though insulin is the first line drug of choice for managing the GDM, but metformin has been recommended for use by national technical guidelines for management of hyperglycemia in pregnancy. DIPSI, NICE, and FIGO are included in that. And as it is most important to achieve euglycemia during pregnancy, it is very convenient to take. The metformin therapy, it is less expensive, requires less monitoring, and if it is preferred by the patient, it may also enhance her treatment adherence. It is an insulin sensitizer. It inhibits hepatic gluconeogenesis and glucose absorption and stimulates the glucose uptake in the peripheral tissue. We start with 500 milligrams OD for a week, then 500 milligram twice a day to a maximum of 2 grams daily. Common side effects being, one second. Yes. So common side effects being pain, diarrhea, which may be reduced by using a sustained release preparation. It is contraindicated in patients with liver, renal, or cardiac dysfunction. It is also useful for obese women or for women who are already on high doses of insulin because it improves the insulin sensitivity and causes less weight gain during pregnancy. Some things which we should know is that sometimes the blood sugar is not controlled with maximum dose of metformin and MNT, insulin is then added. Hypoglycemia and weight gain I've already mentioned are less in comparison to use of insulin. The only consideration with this particular drug is that it crosses the placenta and thereby it raises concerns about potential long-term effects on the child, though the short-term outcomes are generally positive. As far as the controversy is concerned, till now there is no global consensus as to when we should start this particular drug as a primary treatment. Many international bodies recommend the use after 12 to 20 weeks of gestation. Coming to insulin, as I've already said, it is the gold standard. It is safe for both mother and fetus. It does not cross the placenta. It is administered via injection using an insulin pen. And depending upon the type of insulin and blood sugar levels, we may be taken before meals or at bedtime or on waking. So what are the indications for insulin therapy? When the glycemic control is not achieved by metformin or the patient cannot tolerate metformin, and sometimes insulin therapy we have to start even without waiting for the trial of medical nutritional therapy. Those patients who already have GDM, related complications like hypertensive disorder of pregnancy, fetal growth retardation, macrosomia, polyhydramnios, hyperglycemia, which is diagnosed before 20 weeks. If the fasting blood sugar is 110 and PP is more than 140, and patients on antenatal corticosteroids like those with autoimmune disorders or adrenal insufficiencies. So how do you give this injection? The sites are generally the front of the abdomen and this front of the thighs or on the lateral aspect. So the mode is subcutaneous. We use a 40 international unit syringe. The storage is to be, we see to it that the insulin vials have to be made available along with the syringe for the pregnant woman. So she doesn't run around, where is the vial, where is the syringe? Stored in the refrigerator at 4 to 8 degrees centigrade. Never to be kept in the freezer compartment. If by mistake it is kept there, it should be discarded. And once the vial has been opened, can be used for a month. Should not be exposed to direct heat or sunlight. Single insulin syringe can be used safely for 14 injections if it is capped and stored properly. Please, you tell your patients not to clean the needle with spirit. And see that the tip of the needle should not come in contact with anything else except for the clean skin. And these are the sites where she can easily use for giving her insulin injections herself. Now, what are the various insulin preparations available and which are safe for use in pregnancy? We have the rapid-acting ones, Aspart and Lispro. Both of them, the onset is 15 minutes. Peak effect is achieved within an hour's time. Duration is about 3 to 5 hours. The dosing interval is always at the start of each meal. The short-acting one is regular. Onset is about an hour. Peak effect is continues for about 4 hours. The duration of action is 6 to 8 hours. It is given an hour before meals or maybe an hour and a half. Intermediate acting is NPH. Onset is after 2 hours. Peak effects is achieved after 4 to 6 hours. The duration of action is up to 20 hours and it is given either twice or thrice a day. The long-acting ones are insulin detemir and deglutide. Onset is 2 hours and the duration is for almost the entire day. So it can be given once in a day or maybe even later than that. Something we all should know is that insulin analogs like Aspart and Lispro, these are rapidly acting insulin. They have the advantage of over regular insulin as they can be injected at the start of a meal. So she sits with her thali in front of her and she injects herself. And the peak effect corresponds to the highest glucose excursion after a meal. So there is less likelihood of a hypoglycemia because their effect lasts only for 3 to 5 hours. As far as the intermediate and long-acting insulins are concerned, basal insulin suppresses the hepatic glucose production and maintains near normoglycemia in the fasting state. They are safe for use in pregnancy. The insulin type, injection techniques, insulin antibody, the site, and individual patient response differences can affect the onset, degree, and duration of insulin activity. So how do you give this injection? Usually we use a multiple daily injections of insulin. The regime is chosen based upon the patient's blood sugar levels. If it is a fasting hyperglycemia where it is more than 100, then we use basal insulin initiated as zero point 0.2 units per kilogram per day. It can be long-acting insulin analog or a neutral protamine higdon. If the blood sugar levels are high post-meal, then we use rapid or a regular insulin. But if both fasting as well as post-meal blood sugars are high, then she needs multiple daily injections, 3 meal-time insulin and 1 basal insulin. As per the trimester, the dose of insulin is calculated. First trimester is 0.7 units per kilogram. Second trimester is 0.8. Third trimester and labor is 0.9 to 1 unit per kilogram. Patients with morbid obesity will need a higher dose of insulin, 1.5 to 2. The total dose is divided into two. 50% as basal insulin at bedtime and 50% divided between 3 meals. And this is given as rapid or regular insulin before meals. Mixed start insulin has mixture of 30% rapid acting insulin and 70% isophane. Of this, 2/3 is given at breakfast and 1/3 at night. Self blood glucose monitoring is very important. In between, she can go to the lab for an intravenous. What are the targets? Fasting and postprandial self-monitoring of blood glucose are recommended, both for those with GDM and those with pre-existing diabetes to achieve optimal glucose levels. What we want is a fasting level of less than 95 and 2 hours postprandial as less than 120. Now, this is a chart as to how do you manage a patient. She's already been on MNT for 2 weeks. Her blood sugar levels are less than 120. She continues on that, but the blood sugar levels are monitored at least once monthly to see that it is maintained less than 120. If it is more than 120, as I already mentioned, we start with metformin or with insulin. Subcutaneous injections are given 30 minutes before a meal once a day. We calculate the blood sugar levels. If it is 120 to 160, 4 units, 160 to 206, beyond 200, 8 units are given. Again, every third day, the blood sugar levels fasting as well as postprandial are calculated. And then depending upon the sugar levels, if it is less than 120, she continues the same. More than 120, and if it is the fasting is normal, postprandial is higher, then you add 2 units pre-breakfast. If both fasting as well as postprandial are higher, then we give injection insulin 2 doses, same, but you add 2 units pre-breakfast and 4 pre-dinner. This is continued every third day. You keep estimating her fasting and 2 hours postprandial blood sugar levels. The aim is to maintain the levels less than 95 and less than 120. If any of these levels, the sugar rises, then you have to increase the insulin dosage accordingly. Now, this is just a brief. This is one of the Government of India guidelines. How do you do? Self-monitoring is recommended for all patients. She does it 3 to 4 times a day, fasting once daily. And ideally, when she starts this monitoring, it should be 8 hours of overnight fasting. Postprandial is done 2 hours after the onset of meals. So there is another chart which tells you she can do it like on Mondays, she can do for the breakfast. Then on Monday and Tuesday, Wednesday, Thursday, she does it for lunch. I have the slide lower down. because there are many factors apart from a weight that the dose of insulin has to be managed everywhere. Regular and NPH insulin has better efficacy and safety due to flexibility of titration of the prandial insulin depending upon the degree of derangement. In case patient is not comfortable, then you use a pre-mixed insulin. So you initiate with regular insulin dose of 2 units 30 minutes before the meal. If the value is 120 to 150, then 3 units, and accordingly you keep on increasing till you reach the optimum dose. As a practice point, for every 20 to 30 milligram rise in blood glucose, approximately 1 unit of insulin is to be added to the already pre-existing dosage. So GDM insulin is generally given as pre-meal. I'm repeating this again and again, or rapid because these are have a short effect and there is no hypoglycemia. If the control is unsatisfactory, potential source of problem such as a faulty diet or concurrent medication, some illness or infection or stress of lack of exercise and faulty lifestyle should be explored and rectified. So you just don't go on increasing the dose of insulin, sit with her, talk, find out where things could be going wrong because you are being very meticulous. For a single abnormal blood glucose value, just do a dietary readjustments. But if the values are more than 20% beyond what it should be after 1 week of regular titration, then you increase the insulin dosage. So this
Dr.
is what
Deepthi, wind up. Wind up.
So this was just a chart as to how you maintain the blood sugar levels. And while we are giving her insulin, we should be aware of hypoglycemia, how it is to be managed. She should have glucose powder along in her packet everywhere or something sweet to eat, and how it is to be given. As far as intrapartum management is concerned, again, depending upon the blood sugar levels, you manage her. And please remember that the insulin requirements drop after giving birth. So you need to cut down the level to the doses to almost 60% of the antepartum. These are the various guidelines where insulin is considered to be the best modality. Thank you.
As far as GDM management is concerned, Dr. Deepthi has highlighted, you have to be absolutely simple mathematics. If the blood sugars 2 hours is going more than 120, you need to change the medical therapy, as well as you have to be very strict on nutrition as well as on exercise. And as far as labor is concerned, the blood sugars should be around 140 to 160, not more than that. So now we come to the final thing, why we are scared of gestational diabetes. And Meenakshi is going to talk about stillbirth prevention, because whenever there is a gestational diabetes, we're all scared of stillbirth, macrosomia, and birth traumas. So Dr. Meenakshi is going to talk about stillbirth prevention and beyond. I will request Dr. Meenakshi to keep to your time, please.
Yes,
Okay.
sure, ma'am. Thank you, ma'am, for a wonderful opportunity. And it is very
Malti,
important that
present,
we
please.
to prevent
Malti, present.
stillbirth in gestation diabetes mellitus. So my talk is basically on how to optimize the perinatal outcome and reduce stillbirths in gestation diabetes mellitus. Marcy, so, yes. Second, next slide. Yes. Perinatal outcome in gestational diabetes, we know that there are adverse outcomes which are there because of birth trauma. This increased cesarean rate to the tune of 10%. Macrosomia can be seen in almost 14% of gestational diabetes. So the risk and management during and after pregnancy is very, very important, because if the blood sugar is well controlled in gestation diabetic mothers usually have a healthy neonatal birth. So we should always remember that gestational diabetes doubles the risk of large to gestational age as compared to new normal glycemic women. In individuals with obesity, LG prevalence with versus without GDM was higher, 22.3 versus 12.7% respectively. So we need to have a new glycemic control. Next slide. Perinatal outcome in GDM. These are short-term outcomes like increased risk of birth trauma, macrosomia, hypoglycemia, stillbirths, and neonatal ICU admissions, polyhydramnios, increased risk of low birth weight, and IUGR. There are a lot of neonatal morbidities which are seen like hypoglycemia, hyperbilirubinemia, hypocalcemia, hypomagnesemia, polycythemia, respiratory disorders, cardiomyopathy, and the long-term outcome is increased risk of childhood and adulthood obesity and cardiometabolic risk. So there's a whole metabolic syndrome which can develop in the offspring. So if we control the gestational diabetes in the mother, then future generations will be prevented of developing diabetes later in life. Next slide. The HEPO study, which is a largest study which is done on gestational diabetes to find out the outcome of adverse perinatal outcome due to hyperglycemia. They have categorized in seven categories: 1, 2, 3, 4, 5, 6, 7, depending on the blood sugar fasting, 1 hour and 2 hour values. So those who are normoglycemics are usually category 1 and 2 and 3. Category 4 is borderline. Category 6 and 7 are gestational diabetes and over diabetes. So they have seen that when the blood sugar fasting crosses 92, and whenever the 1 hour and 2 hour respectively are in the categories of 6 and 7, that is it is more than 150 and 140 in the 2 hour category, they have seen there's an increased risk of 19th percentile of the birth weight, primary C-section rate rises, clinical hypoglycemia increases, and Corsi peptide all increases. So this is one of the study which say that increasing the hyperglycemic status, blood sugar control of the women, there is adverse outcome. There is a linear progression. So we need to see that maternal hyperglycemia leads to increased transplacental transfer of glucose and other nutrients. Next slide, which induces fetal hyperinsulinemia and in turn accelerated fetal growth, that is asymmetric head size but broader shoulders and increased thoracic and abdominal diameters compared with newborns of mother without diabetes. Next slide. So maternal hyperglycemia independently increase the risk of preterm delivery, cesarean delivery, infants born large for gestational age, NICU admission, neonatal hypoglycemia, and hyperbulimia. Next slide. HEPO study provides an opportunity to revise the diagnostic criteria for gestational diabetes. The proposed criteria for 75 gram glucose 2 hour OTTT are that one or more of the following thresholds are met to be met or exceeded. The patient is categorized as gestational diabetes. Fasting glucose more than 92, 1 hour more than 180, and 2 hour more than 53 has been associated with adverse maternal outcome. Next slide, please. So this was a one systematic meta-analysis. This was published of 156 studies with almost 7,500,000 pregnancies. It has also established that there's increased odds of cesarean section, preterm delivery, low upguard at birth, macrosomia, large for days, respiratory distress, neonatal jaundice, and NICU admission in the gestation diabetes. So this is the same which shows that with insulin use or without insulin use, there is increased risk of adverse outcome in women who are having gestational diabetes. Next slide, please. Next slide. This is a mild gestational diabetes and adverse pregnancy outcome systemic review and meta-analysis of 11,000 women with gestational diabetes and 53,000 non-GDM. Next slide, Malti. Mild GDM has increased risk of cesarean section, preeclampsia, PIH, and shoulder dystocia. Adverse neonatal outcome is also seen where they had seen that the increased risk of LGA, macrosomia, hypoglycemia, low upguard at 5 minutes, hyperbilirubinemia, and NICU. So it is well established there is a connection between gestational diabetes and an adverse maternal outcome. And there are also studies available which shows that once you correct the blood sugar control, the neonatal outcome is optimized. Next slide. Next slide. Next slide. Treatment of FGR. So what happens in gestational diabetes? There is macrosomia as well as sometimes there can be a fetal growth restriction. So timed delivery. Next slide, Mansi. Next slide. इसके next.
तेरे को एक्सटेम्पोर ही बोलना पड़ेगा.
I will do that from this slide only. So time delivery where risk of IUFD increases compared to NICU survival, and we have to balance out the risk of preterm delivery and fetal morbidity and mortality whenever we have a gestational diabetes along with the fetal growth restriction. So timing of delivery is very important. Next slide. Patients with reactive NST and a biophysical score of which are normal with normal AFI. Next slide, Malti. Umbilical artery reverse diastolic flow. They have to deliver these patients between 30 and 32 weeks of gestation, or if diagnosed more than 32 weeks. If there is an umbilical artery flow which is absent, then we have to deliver them early, between 33 to 34 weeks of gestation, or at a diagnosis if diagnosed at 34 weeks. Umbilical artery pulsatility index, which is abnormal, but there is no reduced or absent flow, we should plan to deliver at 37 weeks to optimize the neonatal outcome. So, next slide. Yes. Umbilical artery, which is normal, less than PI percentile, but associated with the estimated fetal weight, which is less than third centile, and there are no comorbidities, we should plan to deliver at 37 weeks. So estimated fetal weight more than third and less than third centile. That is, this is just a small for gestational age, not classically the FGR. With no associated comorbidities, we should try to deliver them between 38 to 39 weeks, but we should be closely monitoring and we should never go beyond 39 weeks. FGR, it is associated with oligohydramnios or comorbidities. Timing should be individualized, but most patients should be delivered between 34 to 37 weeks of gestation. Next slide. So this is the classical, depending on the stage of FGR, how to manage them, which I just elaborated. Stage one is small for gestation age, estimated fetal weight less than third centile, and we should be monitoring them weekly if they have normal Dopplers. Stage 2 FGR, there is a severe placental insufficiency, umbilical artery, there may be an absent or a reverse flow. Then we should be monitoring them more closely, bi-weekly, delivered by 34 weeks. If there is a low suspicion of fetal acidosis, this umbilical artery reverse and diastolic flow, then we may prolong 1 to 2 days, but we should deliver them by 30 weeks. We should not prolong. If there's a high suspicion of fetal acidosis, there is a DV reversal, then we don't have much time. We should deliver them as early as possible, and we should not let the pregnancy go beyond 26 weeks with these findings. Next slide. So I saw in pregnancies with FGR complicated by absent or reverse and diastolic velocity. Cesarean delivery should be considered based on entire clinical scenario. This is very, very important. We should always remember if we are having an FGR, whether in gestational diabetes mother or otherwise, we should time accordingly. All pregnancies where we are delivering in prematurity before 37 weeks, there are recommendations for antenatal corticosteroids. So it should be given to all if delivery is anticipated before 34 weeks of gestation, or when it is estimated between 34 to 37 weeks. If the mother has not received an antenatal corticosteroid previously, then they should and are expected to deliver within the next 7 days should be receiving an antenatal corticosteroids. So hyperglycemia can occur whenever we are giving an anticorticosteroids, corticosteroids for the lung maturity in the gestational diabetes. We should be monitoring their blood sugar closely. We should be admitting them, and the hyperglycemia usually starts 12 hours after the first antenatal corticosteroid dose, and it lasts for usually 5 days. So 5 days after the antenatal steroids, we should be monitoring the blood sugar very closely to these women. We might have to admit them, monitor them, and give insulin as per the sliding scale. Next slide, please. Next slide. Next slide. Neuroprotection in FGR is very, very important. Next slide.
Malti, next one.
In utero, exposure to magnesium sulfate before early preterm birth reduces the incidence of cerebral palsy and severe motor dysfunction in offsprings in pregnancies at a high risk of preterm birth, that is less than 32 weeks, within 24 hours. Magnesium sulfate is administered. So, how do we give it? We give 4 gram IV loading dose over 20 minutes, followed by a 1 gram per hour infusion.
उसको बंद
The
कर दे
infusion
प्लग
is
करके
discontinued at birth or by 24 hours after initiation of infusion if birth has not occurred. So, whenever we are delivering less than 32-weeker baby, we have to give her the magnesium sulfate to protect neuroprotection in the infant, in the neonate. Next slide. So, reducing the stillbirth and intrauterine fetal death. This is very, very important. There are women who had adverse outcome in the previous pregnancies. So if the stillbirth occurred at term, appropriate gestation age baby, the odds ratio of stillbirth in the second pregnancy is to the tune of 1. But if there's a small for gestation age at term, there was a stillbirth in the previous pregnancy, the odds ratio in the subsequent pregnancy is almost 2 times. And SGA, which is moderately preterm, was delivered in the previous pregnancy, then the odds ratio increased to 4 times. And if the stillbirth occurred in the first pregnancy, if the SGA baby, which was very, very preterm, odds ratio of stillbirth in the subsequent pregnancy is almost 8 times. So this analysis has been adjusted for factors such as cigarette smoking, maternal age, interpregnancy interval, and presence of hypertension and antepartum bleeding. Next slide, please. So, what is the strategy to reduce adverse neonatal outcome? This is one. General diabetes management. We remember GDM, general diabetes management is very, very important so that blood sugar is kept under control. Once the blood sugar is under control, adverse neonatal outcome will not occur. So
wonderful.
the strategy to reduce adverse neonatal outcome is universal screening of gestational diabetes. There is no question of screening only a high-risk population. We should be screening for gestational diabetes universally. In India, we must be following the HIPSI criteria, 75 gram glucose, fasting, irrespective of the fasting status, we do it after 2 hours of 75 gram glucose. And if the blood sugar is 140 and above, we should consider them GDM, should put her on strict screening for blood sugar control as well as nutrition. Antepartum fetal surveillance is must. There is serial growth scan which should be done to identify whether the baby is going into macrosomia or going into fetal growth restriction. We need to screen the baby fetus in utero strictly. Strict blood sugar control in the mother is very, very important. Timing and mode of delivery. I have told you FGR baby should be delivered as per their Doppler status as well as whenever there is a macrosomia when there is irregular blood sugar control, they should not be going beyond 38 weeks of gestation. And neonatal care by experienced NICU team should always be there. So diabetes management, we already know that the target blood sugar should be less than 95 and 1 hour post meal should be less than 140 and 2 hour post meal should be 120. We should always be printing these levels on our antenatal charts or just make a note and write that these should be followed and we should strictly follow them in our antenatal clinics. So fetal surveillance is usually annually scanned at 18 to 2 weeks to rule out malformations and diabetes, which are occurring before 20 weeks. Fetal growth scan, next slide, Malti. Fetal growth scan 28 to 30 weeks and 34 to 36 weeks should be done in all
Malti, next
women.
slide.
Malti, next slide.
She can't listen.
Vigilant fetal surveillance is very, very important. Strict daily fetal movement count score. इससे पहले वाली. Strict daily fetal movement count should be done. For the all women, we should tell them that they should count 10 movements in 12 hours. It's a must. And whenever they have a decreased fetal movement count, they should report to the labor room or the health facility as soon as possible. Fetal surveillance by NST and biophysical profile should be done 36 weeks onwards in well-controlled GDM should be started. So GDM on pharmacotherapy or with suboptimal glucose control, fetal surveillance by NST or biophysical profile twice weekly should be started from 32 weeks onwards. Next slide. Delivery should always be institutional delivery because they have a lot of neonatal problems which can be managed by expert neonatology team in hospitals. Timing and mode of delivery is very, very important. Not only the timing, the mode is important, whether to go for cesarean or a vaginal delivery, that depends on the fetal weight. Next slide. Our ACOG in 2018 practice bulletin says GDM, which is controlled on diet, delivered by 40 weeks. GDM controlled on medications, delivered by 39 weeks. GDM, which is uncontrolled, delivered between 37 to 38. Cesarean delivery may be discussed with women with GDM and an estimated weight, which is 4.5 kg of data. But in an Indian setting, I think we should be delivering any baby which is more than 4 kg is macrosomic and above 3.5 kg, they are large. They can be problems associated with shoulder dystocia. So we must be, or everyone should be trained in the shoulder dystocia drills so that to manage them adequately. Next slide. Toxic guidelines 3 to 21. So routine delivery prior to 39 weeks is not recommended due to delayed run maturity. So it's not a blanket that we should be delivering all beyond, earlier than 39 weeks. Only GDM, which is well controlled, induce at 39. Don't go beyond 39 in GDMs. GDM, uncontrolled blood sugar or having associated increased risk of stillbirth or having PIH should be delivered earlier. Timing should be decided on individual cases. Fetal macrosomia more than 4 kg, delivery by cesarean at 39 weeks to avoid shoulder dystocia. Next slide. Yes, this slide. Retrospective cohort study of patients with GDM suggesting that infant mortality rate at 39 weeks was statistically lower than the risk of stillbirth plus infant mortality with expectant management over an additional week. So early term birth, 37 to 38 weeks, 6 days is not indicated as uncomplicated GDM. GDM, which is well controlled, not on pharmacotherapy or on insulin, then they can be taken not beyond 39 weeks. The risk of stillbirth appears to be increased among those who are LGA near term. So whenever there is a macrosomia at term, despite that the blood sugar is controlled, they have a higher risk of stillbirth and they should be delivered earlier. Next, next slide.
While and
Strict
Dr.
blood,
Minakshi, wind up, wind up.
yes, ma'am. It's almost. I'm just going to finish. Strict blood sugar control 2 hourly, especially in patients who have medical management and target ranges. I've already discussed, and it is already discussed in the previous. Next slide, please. Come to shoulder dystocia. We should always remember. Malti, next slide. 2 slides ahead. 50% can't be predicted antenatally. 50% of the shoulder dystocia occurs in fetuses and babies which are less than 4 kg at birth weight. Malti, high birth weight is a major risk factor for shoulder dystocia. Newborns of mothers with diabetes are at increased risk of shoulder dystocia. Next slide. Because they have a higher birth weight and higher chest to head and shoulder to head ratio. Next slide, Malti. Than newborns of mothers without diabetes. So newborns of the mothers with diabetes, they have broad shoulders, they have broad chest, so they are lined up with shoulder dystocia. Malti, next slide, please. Obstetric emergency trained staff for shoulder drill must always be there because any baby which is less than 4 kg can also land up in shoulder dystocia, especially mothers who are GDM, since they have a broad shoulders, broad chest. So each and every person in the labor room should be trained for shoulder dystocia, how to manage them. So this is the incidence of shoulder dystocia in less than 4 kg. This is 0.1 to 1.1% in non-diabetic, but in diabetic it is 3 times increased to 3.7. Between 4 kg to 4.5 kg, the risk in non-diabetic is 1.1 to 10, but in diabetic the risk is 2 to 3 times, 4.9 to 23.1. Above 4.5 kg, the risk is up to 50% having shoulder dystocia. So pregnant, a woman, whoever is more than having a 3 kg baby estimated weight, they should be delivered with everything in hand. We should know about the shoulder dystocia. Above 3.5 to 4 kg, we should be delivering by cesarean section. Next slide. So neonatal morbidities can occur. Next slide. Hypoglycemia, hyperbilirubinemia, hypocalcemia, hypomagnesemia, polycythemia, respiratory disorders, cardiomyopathy, shoulder dystocia, and brachial plexus injury. All high-risk GDM pregnancies should be delivered in centers with neonatology team. Conclusion, like last slide. universal screening for Stillbirth, marking data right, universal screening for GDM, antepartum fetal surveillance, serial growth scans, strict blood sugar control in mother, timing and mode of delivery is important, and neonatal care by experienced pediatricians. So this is very important. Thank you, ma'am.
Meenakshi, you've done a very important part, and I think all of us must know about it. That GDM means that you should be prepared for sudden stillbirth. But what Meenakshi has made it very clear, if the blood sugar controls are absolutely normal, it is very unlikely that you are going to lose the baby. So your aim should be just like mathematics, your blood sugar 2 hours should be less than 120. If they are more than that, then it is calling for troubles. So the red flag sign, as far as the worst outcome is concerned, you must inform each and every time when you are delivering that the pediatrician must know that this particular case is GDM well controlled. But in case if you find that the blood sugar levels are not normal and it has been very unstable, then they should have an alert sign that they can have a problem as far as this particular baby is concerned. I think all of you had made a great presentations because this is a national platform. People who are public people are listening from the Facebook and the YouTube, and the people, nurses, doctors, everybody is listening. So I will like now Dr. Archana Sharma. Archana Verma is a known public speaker, and she has been in charge of the public awareness committee as far the Fox is concerned. What is your message, madam? हिंदी में बताएं, मिक्स अंग्रेजी में बताएं कि पब्लिक को जीडीएम से क्यों डरना चाहिए.
Thank you, madam. GDM is as such a government of India and WHO and FIGO, they all have recognized that this is one of the very important major health issue. सबके लिए सबको पता होना चाहिए, और इसके 1 in 6 में होता है, और इंडियन वुमेन को बहुत टेंडेंसी होती है, दे आर हाईली मेकिंग द कैपिटल इंडिया एज सच, डायबिटीज का कैपिटल बनता जा रहा है. तो इसके लिए हमें बहुत कम मतलब लाइक वी शुड टेल, इसमें 4 पिलर्स होने चाहिए जो अभी चारों स्पीकर्स ने बोले. दैट इज वेरी वेरी मच मेडिकली, like number 1 is screening, diagnosing, and then another level, then when you screen, when you diagnose, then how you diagnose and how you screen, and what are the things you tell to the patient, and this comes under. So there are 4 I must say the life course approaches are there for public awareness point of view. Number 1 is the awareness. Everybody should know ki what they are going to lose. It is a question of 2 lives, maternal health and the fetal health. There are high chances of complications and delivery complications, and fetal outcome are really really very important, because we, as Dr. Meenakshi said, there are high chance if it is uncontrolled. So number 1 is then the diet. What that diet Dr. Renu Chawla very well expressed. बहुत कम कैलोरी रेस्ट्रिक्शन कर देंगे तो भी बहुत इशू होगा, और तो देयर शुड बी अ डाइट चार्ट, हमें क्या खाना है और क्या नहीं खाना, कब कब खाना है. सो दैट शुड बी अनदर थिंग. एंड कब हमें टेस्ट करना है, 2 वीक्स के टाइम में क्या करना है. सो दैट चार्टिंग, गिविंग चार्ट टू द पेशेंट इज वेरी वेरी इंपॉर्टेंट. नंबर 1. Number 2, when there is MNT is not, the nutrition therapy is not useful, then come to the third stage, that is you start using the drugs. So number 1 is A, B, C, D. If we remember, A is for awareness, B is for blood sugar, and then all this ultrasound and NST, or that comes under that, and then the counseling of the patient. The patient should be very well counseled that metformin we are giving you, it's not harmful. You take this, if even if it is not controlling the blood sugar, then don't worry, you have to take some injections, and they are very that is to be given, and then we will take care of that. और दैट इंसुलिन से बहुत डरने की जरूरत नहीं है, ना गायनिकोलॉजिस्ट को ना पेशेंट्स को, व्हेन इट इज नीडेड, और इट इज जस्ट फॉर द सेक ऑफ स्पेशली फीटल कॉम्प्लिकेशन. तो दैट इज वेरी वेरी इंपॉर्टेंट. एज मैडम सेड कि 39 तक बहुत जल्दी घबरा के डिलीवरी नहीं करनी है. जस्ट लाइक देयर फीटल मैच्योरिटी को टाइम लगता है, एंड प्रिफर नॉर्मल डिलीवरी, बहुत जल्दी सिजेरियन पे भी नहीं जाना है, तो एक नॉर्मल डिलीवरी के लिए ट्राई करना है। 39 वीक्स तक हमें वेट कर सकते हैं। अगर दो कंडीशंस होती हैं, पॉलीहाइड्रोमनियोस हो रहा है, मैक्रोसोमिया हो रहा है, ऑन द अदर स्टेज ऑलिगोहाइड्रोमनियोस हो रहा है एंड एफजीआर हो रहा है, तो दोनों ही के ही ट्रीटमेंट डिफरेंट है। और इफ इट इज मैक्रोसोमिया, बी प्रिपेयर्ड, इवन इफ द इट इज आशा एंड एएनएम को उनको स्पेशली बताना है, बहुत खुश नहीं होना है कि बच्चा बहुत मोटा तगड़ा हो रहा है। दैट इज द पॉइंट वेयर द इम्पैक्शन ऑफ द एंटीरियर शोल्डर अकर्स, और जब तब तक वो पेशेंट आएगा तब तक तो उसको बचाना मुश्किल हो जाएगा। एंड इवन इफ इन सम ऑफ द लेबर रूम इफ शोल्डर डिस्टोशिया, दिस इज वन ऑफ द वेरी इंपॉर्टेंट maneuver helper, maneuver Mac Roberts maneuver, every gynecologist should know, and they should try also कि simple procedure helps in 40% में। अगर आपने सिर्फ leg raising भी कर दिया properly तो भी उसको वो anterior का जो impacted है वो different हो जाता है। then where to apply that suprapubic pressure is to be applied, not the fundal pressure। तो ये सब चीजें हैं जो हमें बहुत help करेंगी। तो gynecologist has to be ready, and today's talk was I think perfect, 0 to complete ऊपर तक, जैसे डॉक्टर सीमा has started the relay race and then Dr. Renu. So this is the way every webinar I think should be there, complete presentation, and the best was in between anchoring by respected Dr. Sharda Jain, giving special tips to everybody. So I think I don't have to talk much because सब कुछ अच्छे से पहले से ही बता दिया है सबको। तो मैडम, और दैट BMI पर भी बहुत वो जो है ना, बहुत छोटी सी चीज है, BMI हाइट एंड दैट कैलोरी रिक्वायरमेंट, दैट चार्ट शुड बी विद एवरीबडी, 35 एंड देन 30 and 25 वाला BMI के साथ, and that is very very important। and because in India nowadays obesity and high BMI is one of the reason, and nobody is going listen to patient, they keep on eating and going for ultrasound and thinking if ultrasound is okay everything is okay। so we have to counsel for that, and then protect future, बिकॉज ये तो इसी से लड़ना है हमें, डायबिटीज से, और इसको शुरू से अपने लाइफ स्टाइल प्रोजेक्शन में लाना है। और अब ये तो सबको साथ हाई, बिकॉज ओवर एज पेशेंट्स, ओवर वेट पेशेंट्स, एंड somehow IVF pregnancies, so every baby is precious, so we have to take care।
yes, gestational diabetes को हिंदुस्तानियों को तो बिल्कुल भूलना नहीं है। Present rate is around 20%, but I think in future is going to be almost 30%। बिल्कुल क्लियर बताया डॉक्टर रेनू ने और सबने कि 70% it is medical nutritional therapy, only 20% will require metformin, and only 5% will require insulin therapy। And as far as insulin is concerned, only 5% required। Make it very simple. If you use a mixed chart, which Dr. Deepti has said, 2/3 आपकी डोज जो है वो मॉर्निंग में लेनी, 1/3 आपने इवनिंग में लेना। देखा, you will find that sugar controls are absolutely great। One thing is clear that red flag आपको पता होना चाहिए। पेशेंट को PT हुआ, पेशेंट को IUGR हुआ, it is going to give problem। पेशेंट का blood sugars maintain नहीं, or it is going to give you problems। I think whenever these kind of things are there, you should not deliver them in a 5 or 10 bedded nursing homes। Secondly is, don't go with an idea कि gestational diabetes means cesarean section। No, does not mean। But at the same time, macrosomia may be 4 kg for everybody, but हिंदुस्तानियों के लिए गवर्नमेंट ऑफ इंडिया ने बोला है 3.5 kg is also enough। So I think they require very close fetal monitoring। This is very very important। Now I will ask one sentence from each one of you। डॉक्टर सीमा, आपको क्या कहना है? रेनू, आपको क्या कहना है? दीप्ति, आपको क्या कहना है? मीनाक्षी, आपको क्या कहना है? एंड फाइनली अर्चना जी, आपको क्या कहना है? डॉक्टर सीमा।
Thank you, ma'am। I think to prevent and to treat the complications and to keep our future generations healthy, हमें antenatally ही अपने आप को अवेयर करना है, अपने को भी
स्क्रीन करना है, बस
स्क्रीन करना है, काउंसल करना है पेशेंट्स को, एंड प्रिवेंट करना है कॉम्प्लिकेशंस।
डॉक्टर रेनू,
प्रेगनेंसी में एम नहीं करना है कि हमें वेट रिड्यूस करना है, बट क्वालिटी ऑफ फूड इज इम्पोर्टेंट, क्वांटिटी इज इक्वली इम्पोर्टेंट। अच्छी क्वालिटी का लो ग्लाइसेमिक इंडेक्स वाला खाना अगर लेते हैं और जुडिशियसली फॉलो करते हैं जो भी उनको डाइट चार्ट दिया जाता है, तो मुझे लगता है कि बहुत सारी कॉम्प्लिकेशंस को हम अवॉइड कर सकते हैं।
डॉक्टर दीप्ति, सिंपल थिंग एज फॉर द ट्रीटमेंट पार्ट इज कंसर्न, जिससे लोग डरे ना।
जब एक बार डायग्नोसिस हो गया डायबिटीज का और आपको शुगर लेवल से पता चला कि इंसुलिन लगना है, जैसे डॉक्टर रचना ने कहा, डरना नहीं है। सेल्फ ब्लड ग्लूकोज मॉनिटरिंग सीखिएगा, खुद से करिएगा, क्योंकि यही आपको गाइड करेगा कि आपकी शुगर ज्यादा, अगर आप डरेंगे और लैब के लिए डिपेंड करेंगे, दैट विल बी वेरी डिफिकल्ट फॉर यू. डू इट योर सेल्फ, इट इज वेरी इजी. मेंटेन अ
डॉक्टर
रिकॉर्ड.
मीनाक्षी, यस 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 डॉक्टर दीप्ति।
नहीं मैम, यू हैव टू मेंटेन अ रिकॉर्ड. उनको डायरी बनाकर देते हैं कि आपको फास्टिंग और नाश्ता करने के 2 घंटे बाद इस प्रकार से करते रहिएगा, और 15 दिन में एक बार लैब से होगा, और डॉक्टर के पास आपकी विजिट्स थोड़ी और फ्रीक्वेंट होंगी. दैट इज ऑल.
I also feel that once in a month वाला थोड़ा थोड़ा ज्यादा too much हो गया. Once in a week they should start doing it. Even if it's well controlled, it is good that they should be doing self blood glucose monitoring. डॉक्टर मीनाक्षी, आपने थोड़ा सा डराया लोगों को कि एक बार स्टिल बर्थ हो गया तो अगली बार दो गुना चांस है, और IUGR हो जाएगा तो आपका 3 गुना चांस है. उसको थोड़ा सिंपल करके उनको बिना डराए हुए बता दीजिए कि व्हाट शुड बी द टिप्स.
ब्लड शुगर कंट्रोल रहेगा तो ये सारी प्रॉब्लम्स नहीं आएंगी.
होएगी नहीं.
ब्लड शुगर फास्टिंग लेस देन 95 एंड 2 घंटा खाना खाने के बाद 120 से कम होगी तो बेबी पे कोई असर नहीं पड़ेगा. अदरवाइज बहुत सारी प्रॉब्लम्स हो सकती है, उसको हम ब्लड शुगर कंट्रोल से आराम से बचा सकते हैं.
आपने जैसे मुझे बताया, मैंने भी माय एक्सपीरियंस हैज बीन देयर फॉर अ वेरी लॉन्ग, एंड आई आल्सो फील वंस यू टेल देम दैट अनस्टेबल ब्लड शुगर होगा तो सारी कॉम्प्लिकेशन बच्चे की आएंगी, एंड यू फाइंड दैट दे फॉल इन लाइन एंड उनके ब्लड शुगर्स आर नॉट अनस्टेबल. डॉक्टर अर्चना, लास्ट वर्ड फ्रॉम यू.
जेस्टेशनल डायबिटीज 3 ही चीजें याद रखनी है. पेशेंट को काउंसिल करने से पहले स्क्रीन करेंगे तो डिटेक्ट अर्ली. नंबर 2, एक्ट वाइजली, एंड बिकॉज सब कुछ अगर हम उस पेशेंट को समझा के करेंगे तो एक ही वर्ड है, एक्ट वाइजली. हर जगह सेम नहीं होता है, टेलर मेड होगा सब कुछ. एंड देन सेव द फ्यूचर, that is the only thing, and deliver safely, provide safer world for the pregnant woman.
आपने बहुत अच्छी तरह किया कि सेव द फ्यूचर. काउंसलिंग इन जेस्टेशनल डायबिटीज इज वेरी इंपॉर्टेंट, स्पेशली पोस्टपार्टम. पोस्टपार्टम आपने बताना है कि मैडम आप लाइफस्टाइल चेंज नहीं करोगी तो आपको प्रॉब्लम होगी, और बच्चे को भी आप मोटा रखोगी तो बच्चे की भी प्रॉब्लम होगी. तो ये जो काउंसलिंग है बतानी बहुत जरूरी है कि आपका 6 वीक्स टू 3 मंथ्स में एक आपका वही ओरल GTT कराएंगे 75 मिलीग्राम से, अगर ये नॉर्मल है फिर 1 साल के बाद, और उसके बाद एक ईयरली होगा 3 साल तक, उसके बाद 3 ईयरली होगा. और आप फिजिशियन के पास थोड़ा समय समय पर एक बार एनुअल चेकअप की तरह जरूर जाएंगे. सो आई थिंक जेस्टेशनल डायबिटीज वन शुड नॉट गेट स्केर्ड, एंड एज एवरीबॉडी हैज सेड, इफ यू जस्ट फॉलो दीज टिप्स, आई अगेन रिपीट, अगर ब्लड शुगर आपका 2 घंटे का 120 से कम है, आपके बच्चे को कोई प्रॉब्लम नहीं होने वाली. बट यू हैव टू सेल्फ ग्लूकोज मॉनिटरिंग. आपको कोई लैब की जरूरत नहीं, आपने खुद इसको चेक करना सीखे, और बच्चे के लिए मूवमेंट्स का ध्यान, और सब जो जैसे जैसे डॉक्टर्स बुलाएं आपको जाना जरूरी है. घर में डिलीवरी किसी हालत में नहीं करानी. So thank you very much, all of you. It had been a great month as far as diabetes is concerned, and gestational diabetes, because we are gynecologists, we have to be very careful. So awareness has to be created. So thank you very much. We do not have questions, but लोगों के दिमाग में 3 question है. I will ask Dr. Meenakshi, अगर gestation diabetes हो गई तो क्या हर टाइम cesarean section होगा, Dr. Meenakshi?
नो, हर बार सिजेरियन सेक्शन नहीं होगा. वो सिर्फ बहुत ही कंडीशंस होती हैं. अगर बच्चे का वजन बहुत ज्यादा हो जाता है तो ही हमें सिजेरियन करना पड़ेगा, अदरवाइज नॉर्मल डिलीवरी हो सकती है. और इसके लिए बहुत इंपॉर्टेंट है थ्रू आउट प्रेगनेंसी ब्लड शुगर कंट्रोल में रहे.
डॉक्टर साहब, रेड फ्लैग साइन किसी ने पूछा है इन GDM. डॉक्टर दीप्ति नाथ.
Madam, the red flag sign is blood sugar monitoring levels. And the second, the red flag sign may be an ultrasound, whether it is FGR or it is going into large for date with polyhydramnias.
And I will say 3 more things. PT अगर अपीयरेंस होना शुरू हो जाए, पेशेंट का डिक्रीज फीटल मूवमेंट्स होना चाहिए, और अगर पुअर आपका ग्लाइसेमिक कंट्रोल है, these are the red flag signs that you must get alerted, and you must see that the pediatricians also get alerted. So thank you very much, all of you. Thank you very much. Shriyan, the platform is yours now. Madam Shriyan?
Yeah. Thank you so much, ma'am. Thank you, everyone, for joining us today and conducting such wonderful session for us. Thank you so much.
Thank you very much.
Thank you.